You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
The Antipsychotic Universe. 2 generations, 1 mission. Think of antipsychotics like 2 generations of bouncers at the dopamine nightclub. The first generation antipsychotics, FGAs, also called typicals, are the old-school, no-nonsense bouncers. They grab dopamine by the collar and block the D2 receptor hard. They're effective, but they're rough. They cause a lot of movement side effects because they don't know how to be gentle. The second generation antipsychotics, SGAs, also called atypicals, are the newer, smoother bouncers. They still block D2, but they also block serotonin 5-HT2A receptors, which acts like a chill pill that softens the D2 blockade in the movement areas of the brain. The trade-off? They tend to make people gain weight and mess up their metabolism instead. Neither generation is better, they just have different side effect trade-offs. Mechanism of action. The receptor story. All antipsychotics work by blocking dopamine D2 receptors. That's the non-negotiable foundation. The antipsychotic effect happens when you block about 60 to 80% of D2 receptors in the mesolimbic pathway, the psychosis pathway. The problem is that D2 receptors also live in the nigrostriatal pathway, movement, the tuberoinfundibular pathway, prolactin, and the mesocortical pathway, cognition/motivation. Block D2 in those areas and you get movement disorders, elevated prolactin, and worsened negative symptoms. FGAs, typicals, are primarily D2 antagonists with varying degrees of blockade at alpha-1 adrenergic, histamine H1, and muscarinic receptors depending on the specific drug. High-potency FGAs like haloperidol have very tight D2 binding, great for psychosis, terrible for movement. Low-potency FGAs like chlorpromazine have looser D2 binding, but hit histamine and alpha-1 receptors hard, causing sedation and orthostatic hypotension instead of EPS. Think of it as a seesaw. More D2 blockade equals more EPS, but less sedation. Less D2 blockade equals less EPS, but more sedation and weight gain. SGAs, atypicals, add 5-HT2A receptor antagonism on top of D2 blockade. Blocking 5-HT2A in the nigrostriatal pathway releases dopamine in that area, which counteracts the D2 blockade and reduces EPS risk. This is the serotonin-dopamine balance theory. SGAs also bind to D2 receptors more loosely and dissociate faster, fast-off theory, which means they block D2 just enough for antipsychotic effect, but let go quickly enough to avoid movement problems. Clozapine has the lowest D2 affinity of all antipsychotics, which is ironic because it's the most effective one. Third-generation agents like aripiprazole, brexpiprazole, and cariprazine are D2 partial agonists. They don't fully block D2. They turn the volume down to about 30% instead of shutting it off completely. This means they stabilize dopamine. In areas with too much dopamine, mesolimbic, they reduce activity. In areas with too little, mesocortical, they boost it slightly. This gives them the lowest EPS and metabolic risk of all antipsychotics. Memory trick: FG as equals D2 bouncers. Movement problems? SG as equals D2 plus 5, HT2A bouncers, metabolic problems. Third gen equals D2 dimmer switches, fewest side effects. Extrapyramidal symptoms, EPS, the movement disaster zone. EPS are caused by D2 blockade in the nigrostriatal pathway, the brain's movement highway. FG has caused significantly more EPS than SGAs, but SGAs are not free of EPS risk. especially risperidone and paliperidone at higher doses. There are 4 types of EPS, and the timing of onset is the key to remembering them. Think of the mnemonic 4 A's in 4 time zones. Acute dystonia hits first, within hours to days of starting an antipsychotic or increasing the dose. It presents as sudden, sustained muscle contractions. Think torticollis, neck twisting, ocular gyric crisis, eyes rolling up, trismus, jaw clenching, or opisthotonus, back arching. It's terrifying for patients and is a medical urgency. Young males on high-potency FGAs are at highest risk. Treatment is IM benztropine, cogentine, 1 to 2 milligrams, or IM diphenhydramine, Benadryl, 50 milligrams. Works within minutes. Akathisia hits next, within days to weeks. It's an intensely uncomfortable inner restlessness. Patients can't sit still, pace constantly, and feel like they're crawling out of their skin. It's the #1 reason patients stop taking antipsychotics on their own. It is not anxiety, it's it's a motor phenomenon. Treatment options include dose reduction, switching to a lower-risk agent, or adding propranolol, a beta blocker, benzodiazepine, or mirtazapine. Anticholinergics, benztropine, are less effective for akathisia than for other EPS types. Drug-induced Parkinsonism, pseudo-Parkinsonism, develops over weeks to months. It looks exactly like Parkinson's disease: bradykinesia, cogwheel rigidity, resting tremor, shuffling gait, masked faces. The difference is it's caused by medicati. It's caused by medication, not neurodegeneration. Treatment is benztropine 1 to 2 milligrams BID or trihexyphenidyl, or dose reduction/switching. Tardive dyskinesia, TD, is the late complication, developing after months to years of antipsychotic exposure. It presents as involuntary repetitive movements, most commonly lip smacking, tongue protrusion, chewing movements, and finger/toe writhing. TD is potentially irreversible, which is what makes it so feared. The annualized incidence is approximately 6.5% with FGAs versus 2.6% with SGAs, and the prevalence is about 32% with FGAs versus 13% with SGAs. Risk factors include older age, female sex, especially postmenopausal women, longer duration of treatment, higher cumulative doses, and a history of acute EPS. Among SGAs, olanzapine and aripiprazole have the lowest TD risk, while risperidone has a relatively higher risk among SGAs. Quetiapine and clozapine are associated with the lowest TD risk overall. TD treatment. 2 FDA-approved VMAT2 inhibitors are the first-line treatments: valbenazine, Ingrezza, and deutetrabenazine, Austedo. They work by depleting presynaptic dopamine, reducing the involuntary movements. Valbenazine is dosed once daily. Deutetrabenazine is dosed twice daily, though a once-daily formulation is now available. Both have demonstrated efficacy in reducing AIMS scores in randomized controlled trials. Other strategies include lowering the antipsychotic dose or switching to quetiapine or clozapine, lowest TD risk. The AIMS, Abnormal Involuntary Movement Scale, should be used to screen for TD every 6 to 12 months, every 3 months in high-risk patients like the elderly. EPS timeline memory trick: hours, days, weeks, months equals dystonia, to akathisia, to Parkinsonism, to tardive dyskinesia. Early EPS equals treatable and reversible. Late EPS, TD, equals potentially permanent. Neuroleptic malignant syndrome, NMS, the life-threatening emergency. NMS is the scariest complication of antipsychotic use. A rare 0.012–0.02% of patients on antipsychotics, but potentially fatal idiosyncratic reaction caused by excessive dopamine blockade. The mortality rate remains approximately 10% even with modern management. It typically occurs within 72 hours to 30 days of starting or increasing an antipsychotic, but most cases develop within the first 1 to 2 weeks. The 4 cardinal features can be remembered with the mnemonic FARM. Fever, greater than 100.4 degrees Fahrenheit/38 degrees Celsius, often spiking to 40 degrees Celsius plus. Autonomic instability, tachycardia, labile blood pressure, diaphoresis, tachypnea. Rigidity, lead pipe rigidity, severe, generalized, unresponsive to anti-Parkinsonian agents, and mental status changes, delirium, confusion, stupor, or coma, often the earliest sign. Key lab findings include massively elevated creatine kinase, CK, often greater than 10,000 units per liter, sometimes greater than 100,000, from rhabdomyolysis, along with leukocytosis, elevated WBC, metabolic acidosis, elevated liver enzymes, and decreased serum iron. The CK elevation may not be present early. Normal CK at onset does not rule out NMS. NMS treatment follows a tiered approach. Step 1. Stop the offending antipsychotic immediately. This is the single most important intervention. Step 2. Aggressive supportive care, IV fluids. Target urine output 200 to 300 milliliters per hour to prevent renal failure from rhabdomyolysis. Cooling measures for hypothermia, monitoring in an ICU setting, and correction of electrolyte abnormalities. Step 3. Pharmacological treatment. Dantrolene is a direct-acting skeletal muscle relaxant that inhibits calcium release from the sarcoplasmic reticulum, reducing rigidity and hypothermia. Bromocriptine or amantadine are dopamine agonists that counteract the dopamine blockade causing NMS. Lorazepam can help with mild rigidity. Step 4. ECT. Electroconvulsive therapy may be considered for refractory cases, particularly when catatonic features are prominent. NMS versus serotonin syndrome, the exam trap. Both cause fever and altered mental status, but NMS has lead pipe rigidity and develops over days, while serotonin syndrome has clonus, hyperreflexia, and myoclonus and develops over hours. NMS equals rigid and slow. Serotonin syndrome equals twitchy and fast. After NMS resolves, wait at least 2 weeks before cautiously restarting an antipsychotic. Choose a different class, preferably a low-potency SGA like quetiapine or clozapine, start at the lowest dose, and titrate very slowly with close monitoring. Metabolic syndrome, the silent killer. Metabolic side effects are the Achilles heel of SGAs. While SGAs cause fewer movement problems, they significantly increase the risk of weight gain, type 2 diabetes, dyslipidemia, and cardiovascular disease. This is not just a cosmetic issue. Patients with schizophrenia already die 15 to 20 years earlier than the general population, largely from cardiovascular disease, and metabolic side effects of antipsychotics contribute to this gap. The metabolic risk hierarchy. Not all SGAs are created equal. The ranking from highest to lowest metabolic risk is clozapine and olanzapine are the worst offenders. They cause the most weight gain, often 10 plus kilograms in the first year, the highest rates of diabetes and dyslipidemia, and can cause metabolic disturbances even without weight gain through direct effects on glucose and lipid metabolism. Quetiapine is intermediate high risk. Risperidone and paliperidone are intermediate risk. Aripiprazole, brexpiprazole, cariprazine, lurasidone, and zeprasidone have the lowest metabolic risk. Aripiprazole is the only antipsychotic that showed either no change or improvement across all metabolic parameters compared to placebo in a network meta-analysis of 18 antipsychotics. Memory trick: cool drugs cause weight gain. Clozapine, olanzapine, and quetiapine are the metabolic monsters. Lay's drugs are lean. Lurasidone, aripiprazole, ziprasidone are metabolically friendly. Why does this happen? The metabolic effects are driven primarily by blockade of histamine. H1 receptors increases appetite and weight. Serotonin 5-HT2C receptors increases appetite, and muscarinic M3 receptors directly impairs insulin secretion from pancreatic beta cells. Clozapine and olanzapine have high affinity for all three of these receptors, which explains why they're the worst metabolic offenders. Aripiprazole, lurasidone, and ziprasidone have low affinity for these receptors, explaining their metabolic safety. Metabolic monitoring protocol, the schedule every PMHNP must know. The monitoring schedule is standardized across multiple guidelines and is high yield for exams. At baseline, before starting any antipsychotic, obtain weight, BMI, waist circumference, blood pressure, fasting glucose or HbA1c, and fasting lipid panel. Also obtain a personal and family history of diabetes, obesity, dyslipidemia, hypertension, and cardiovascular disease. At 4 weeks, recheck weight and BMI. If the patient has gained greater than or equal to 7% of baseline body weight, this is considered clinically significant and should trigger a discussion about switching to a more metabolically friendly agent. At 8 weeks, recheck weight and BMI again. At 12 weeks, 3 months. This is the big checkpoint. Recheck weight, BMI, blood pressure, fasting glucose or HbA1c, and fasting lipid panel. This is when metabolic changes from SG as typically become measurable. For clozapine and olanzapine specifically, the VA/DOD guidelines recommend metabolic labs at 3 months. Ongoing, weight and BMI at every visit for the first 6 months, then quarterly. Fasting glucose/HbA1c and lipid panel annually. Some guidelines say every 12 to 16 weeks for high-risk agents like clozapine/olanzapine. Blood pressure annually, EPS/TD monitoring. Screen for acute EPS at every visit until dose is stabilized and after any dose increase. Screen for TD using the AIMS every 6 to 12 months for most patients, every 6 months for patients on high EPS risk drugs, and every 3 months for elderly patients on high-risk drugs. Memory trick for monitoring timeline. 1, 2, 3 annual equals month 1, weight, month 2, weight, month 3, weight plus labs, then annual labs, plus aims every 6 to 12 months. Special antipsychotics every PM. HNP must know clozapine, Clozaril, is the gold standard for treatment-resistant schizophrenia. It's the only antipsychotic with proven superiority for patients who have failed 2 adequate trials of other antipsychotics. It has the lowest EPS and TD risk of any antipsychotic. However, it carries the risk of a granulocytosis, approximately 0.8%, which requires mandatory REMS monitoring with regular absolute neutrophil count, ANC monitoring, weekly for the first 6 months, bi-weekly for months 6 to 12, then monthly thereafter. Other serious risks include myocarditis, approximately 1%, seizures, approximately 4%, dose-related, severe constipation/ileus, and the worst metabolic profile of any antipsychotic. Despite all this, clozapine is associated with the lowest all-cause mortality of any antipsychotic in real-world data. The metabolic harm is outweighed by its superior efficacy and anti-suicide properties. Aripiprazole, Abilify, is the metabolic champion. Lowest weight gain, lowest diabetes risk, lowest lipid changes. It's a D2 partial agonist, so it can paradoxically worsen psychosis in some patients by adding dopamine activity in an already hyperdopaminergic state. Unique side effect: akathisia is relatively common. Risperidone/paliperidone are potent D2 blockers among SGAs, effective but carry the highest prolactin elevation risk of all SGAs, can cause galactorrhea, amenorrhea, sexual dysfunction, and long-term osteoporosis risk. Paliperidone is the active metabolite of risperidone and is available as a long-acting injectable, Invega Sustenna/Trinza. Quetiapine, Seroquel, has very loose D2 binding, low EPS risk but high sedation, strong H1 blockade, and significant metabolic risk. At low doses, 25 to 100 milligrams, it acts primarily as an antihistamine/sedative, which is why it's widely misused for insomnia. Ziprasidone, Geodon, is metabolically friendly but carries the highest QTc prolongation risk among SGAs, requires baseline ECG, and must be taken with food. Absorption doubles with food. Lurasidone, Latuda, is metabolically clean and FDA approved for bipolar depression, both monotherapy and adjunctive. Must be taken with at least 350 calories of food for absorption. Cannot be used with strong CYP3A4 inhibitors or inducers.
Thanks for watching. Like and subscribe for more content.